everyone. How y'all doing today? I welcome. This is Dr. Janice Makela. I am a palliative care doctor, a hospice doctor, and a cannabis specialist. I've been practicing medicine for over 20 years, and I've created these live streams to talk with people and answer their questions. Obviously, a lot of people have questions about cannabis, and certainly that's what I'm here for. Also, I can answer your questions um, about hospice or geriatric topics. If you have a loved one with dementia or are doing advanced directives, planning for hospice, stuff like that, I can help you, answer these questions. Obviously, I can't be asking personal questions, should I take this drug? Should I do that? That's between you and your doctor. So I can only provide education and kind of steer you in the right direction. The other thing to know is that this isn't really a podcast, it's a live stream. What that means is you are the co host. So, while certainly I can come with thoughts and ideas and I can talk nonstop if I need to, you are the co host. You come on with questions, with thoughts, with comments. And if you'll see in the side of the screen, there's actually a little chat screen over there. As you chat, as you put stuff, your comments will be up there. And we will talk about that. So, welcome again. And usually I end up talking a little bit while people are warming up. But as you come, feel free to throw your name up on the chat screen and say hi. Always love knowing who's here on the other side. It's always a good thing. Chamomile tea. So, welcome. Let me just check a few little things on the tech while we're waiting here as getting started. But I wanted to just first introduce myself, and a little bit about what we're doing here, and thank everyone for coming. Really do appreciate it. The other thing is just, well, you know what? I'll get started. I'm going to start talking a little bit about cannabis and heart disease. There's been a lot of studies coming out about heart disease and cannabis. Now, cannabis, forever, because people smoke it, we think of it like tobacco. And just like tobacco, we're concerned, if you smoke tobacco, you're going to have heart disease. You smoke tobacco, you're going to get lung disease. Can you get the same things with cannabis? And it is not entirely clear, to be honest. The lung disease issue, it seems like people can get a little bit of bronchitis. Now, bronchitis is a condition where you have thickening of the mucosal lining in the tube, your bronchioles that lead to your breathing tube, right? And that can get kind of thickened and it can get mucus filled, and it leaves you with a little bit of a chronic mucousy cough. Now, if it gets really bad and it starts to impair your ability to breathe, we call that COPD. So you can have bronchitis without COPD. Now, in smoking is linked to COPD and emphysema and bronchitis. Cannabis, the data seems to show that it only is linked to bronchitis, but there doesn't seem to be a lot of linkage to COPD and emphysema, even in chronic smokers of cannabis. And I honestly suspect that's a dose-related thing. Simple truth is, when people smoke, they're smoking a pack of cigarettes a day. That's 20 cigarettes. So if they have a 2-pack habit, that's 40 cigarettes. A person who smokes cannabis is very rarely smoking more than a joint, if that, a day. So you're just not getting as much combustible material in your lungs. And so I think over the course of a lifetime, you're not causing as much damage. Now, the question is, can it cause heart damage? There was a recent study that looked at heart disease and cannabis, and it showed the question of if you have heart disease, are you now or can if even if you use gummies, can it increase your risk of heart disease? And this made the news because everyone was like, "Oh my gosh, yes, yeah, even gummies can do this," because everyone thought it was just the smoking. That study was really, really small. And it didn't actually look at heart disease. It looked at the blood vessels and certain things and markers in the blood vessel that suggested inflammation, that it might develop problems over time. So it's not the end all and be all. Then there was a meta analysis that came out recently where they looked at a lot of different studies and said heart disease might be caused by chronic cannabis use. And based on this study, that the preponderance led to, um, yes, it can. Now, I, looking at that, I, it's hard to say because there's also another study that they don't make the news that they talk about that looked at cannabis that's been looking at risk factors for heart disease over the last 30 years, the Cardia study. And the Cardia study has a subset of people who have been chronically using cannabis. And over 30 years, they're not seeing any increased risk of heart disease in the Cardia study yet. So I personally say the jury is out. Now, personally, as a doctor, I advocate very much strongly medical cannabis, but the question is recreational users, what do you do with this information? Now, you know, there are people who use it recreational, and how do you do it safely? I think one of the key points is we can't be entirely sure that it's going to be everything safe. I mean, everything we do is going to have some sort of risk factors, whether you eat a hamburger or whether you do, some on, yeah, whatever, right? There's always going to be things that are going to be risky that in the realm of things are not going to be tipping your body towards wellness. Now, with cannabis, there are a lot of people who do use it for wellness and it helps them with certain things. But I think the one thing we can talk about is if there is a risk for heart disease. And first of all, let's just say there might be. The data's out. We don't need to get defensive and say, "Oh my gosh, no, don't talk bad about cannabis." It might be, and it's okay. What that tells you is that you should probably just use the least amount that you need to, right? At the very least, unless something really slam dunk comes by and says, "Oh my God, it blows smoking out of the water when it comes to heart disease," and we're not seeing that data. Um, it would suggest that if you're using cannabis recreationally, that you use the smallest dose that's comfortable or that you can. And if you find you're progressively using higher and higher doses and you're needing higher and higher doses to kind of get the effect that you want, that maybe you should consider titrating down. There's a lot of different protocols. I know Dr. Sulak has one that he calls it a tea break, where you take a little break and then you reset your receptors so you don't need as much. The perk with that is you save money because then you don't need as much cannabis to actually get the same effect, right? So I would say, you know what? The jury's out. I'm not going to be alarmist and say, "Oh my gosh," because I don't think the data support that. At the same time, um, and I think the data is not the best. Dr. Kaplan in his Substack wrote some really good breakdowns of these articles and why they actually have some limitations. So again, Wouldn't necessarily panic, but at the same time, I would say be smart. Don't use more than you need to. Be aware that it's a possibility. Data in the future might show that. But, you know, now for medical patients, this is a different story because for a medical patient, everything in medicine is risk benefit. So in medicine, we say the risk of drug A versus the benefit of drug A, the risk of treating this disease versus the risk of not treating this disease. So everything is risk and benefit. So, for example, something like cancer, chemotherapy drugs are notoriously nasty. Why? Because you're fighting cancer and you're fighting for your life. And you say, wow, the risk of this, of causing numbness for the rest of my life in my fingertips and toes of this chemo versus the risk of dying of cancer weighs out, to say, yeah, let's take the chemo. But sometimes some of my very frail patients, the risk of chemo outweighs the risk of the cancer. It's like, okay, hospice with cancer, you're actually going to live longer than if I give you the chemo and you die of an infection from the chemo making you sick. So, everything is risk and benefits. So, when we look about heart disease and the risk of heart disease and cannabis in the medical patient, it's important to talk about the risk and benefits. What this means is that maybe if you have a bad heart, I'm going to be really careful about whether or not cannabis is used for you. I'm going to be thinking about it one way or the other, and it's kind of maybe, maybe not. Now, if I'm doing this in my palliative hat, or if you have something that's worse than that, then yeah, if you're using it for your chemo or so you can tolerate your chemo and fight the cancer, well, yeah, I mean, heck, we have chemo drugs that can hurt your heart. Uh, there are several of them that can cause heart problems. But again, people look at that and say, well, heart problems versus cancer. I'll take, you know. So again, risk benefit. I hope that makes sense. Let me see real quick and look and see if there's any questions or anything like that, if we're getting anything. Right now, oh yeah, nothing quite yet. So anyway, I hope that people who are here, you know, feel free and comfortable to chime in. But that was the first thing I just wanted to talk about. Mm. This is cannabis after hours, after work, right? And so I'm here to talk about a lot of different things. One of the perks I've added of the 7 o'clock class is that at 7 o'clock, people are out of work. I've been doing a 3 o'clock on Wednesday, and with the 3 o'clock on Wednesday, people are at work. They have to, maybe their server. They can't talk about cannabis at work, or you're working. You actually have to do your job. So this is here as an option for someone who, at the end of the day, can sit down, watch this, interact, socialize. We talk about things with the cannabis. The other thing is, you know, being non-work hours, we can talk about other things like the effect of cannabis on sexuality and stuff like that. Um, get a little spicy, I guess, as they say, if we need to. But so we can talk a little bit about that type of thing. Now, an interesting thing about that is that there is a lot of data, particularly in women's health, surprisingly, that women actually can benefit who have pelvic pain syndromes. So, endometriosis, really bad period pain, dyspareunia, painful sex, right? That those types of situations, vagismus, really painful contractions during sex, there's that people who have these types of situations that cannabis can actually help that. The yeah, the we got an answer. We got a question. So we will get back to that question. But that was the interesting thing was that there's actually a lot of data that again you have CB1 receptors in the genitalia in the reproductive organs and that some of this might be actually related to that and to the CB1 receptors might be part of the problem with pelvic pain and so the cannabis can actually help pelvic pain particularly in women. Now we got a question from Eduardo here. Let me just put it up. And he says, medicinally, we use microdoses and carefully manage the cannabinoids involved. The cardiovascular risk is mainly associated with the CB1 receptor in the heart, so we can't work with other so we can work with other cannabinoids like CBG, CBGA, exactly CBD or THC instead. What do I think? You know, I think there's some interesting things. I agree with you. I think this is very dose dependent, and in the medical world, we're using small doses. As a geriatrician, I'll start people on, I would recommend someone starts at 2.5, even 1.25 milligrams of a dose until they get used to it and titrate up. So this is compared to a lot of the recreational users, which are using a much higher dose. Though you do see some of the medical users in the MS world who are using a lot of it times they have self-treated because doctors weren't accepting to the fact that they needed it for their MS and so they would just get it and use it. And so I think but it's also possible that in MS you have a broken endocannabinoid receptor. So it's possible people with MS might need higher doses. It's hard to say at this point. But yeah, so I agree. I think microdoses are going to have less of an effect in the heart and then the CB1 receptor in the heart. But you know what? I That's my thought too is that the CB1 receptor, but you talked about THCA and the CBG and those work in the PPAR receptor. And I don't have any data for this. This isn't anything based off of a clinical study, but we know that those act on the PPAR receptor. And rosiglitazone and pioglitazone, which were diabetes drugs that came out about 20 years ago worked on the PPAR receptor, which may be why those drugs can be so metabolically helpful, right? But the PPAR receptor, if you remember, rosiglitazone got pulled because of cardiac toxicity. I do not know if there's any like bleed over in that PPAR receptor with that could be. I'm not sure if we have a good mechanism of action as to why cannabis would be causing it. I was trying to look at it. The other possibility is COX2. There's a lot of interplay between THC and COX2. And I was trying to figure out, I was talking to some of my chemist friends who study the ECS, and they didn't think there was an interaction in that. I mean, there's an interaction, but if you remember, COX2 inhibitors were very big, about 20 years ago, and one of them got pulled off because, again, cardiac toxicity. And so I think there's a couple different mechanisms beyond just the possibility of CB1, which is why I kind of keep an open mind about the possibility it could be. I don't want to just say, oh no, this is big pharma coming out against cannabis. It could. And what that means is I think you're right. We be careful in our medical patients. We're going to use lower doses. We're going to use the lowest effective dose so that we can work with a patient. And then, like you said, I agree. You might want to start with something like a CBD or a CBG and see how it works. For sleep, I often suggest starting with a CBN, right, and seeing how it helps. So I agree. We can see how that works. So, yeah, very good point, Eduardo. The hmm, I talked about sleep a little bit. And now sleep's interesting. A new study just recently came out talking about sleep, suggesting that THC probably doesn't help as great with primary insomnia. You know what? Study after study kind of seems to say that primary insomnia, THC doesn't help it. It lowers the REM, lowers the amount of sleep. When you subjectively ask people, how did you sleep? How did you feel? People say they felt great. When you put someone in a sleep study and look at their sleep monitor and say, how good is their sleep? It continually shows that it's not great. Now, I think there's a little bit of I won't say bias, but a little bit of selection. Because I think when you're dealing with primary insomnia, where sleep hygiene and actually some cognitive behavioral therapy is going to be your first and best choice, that's going to be a different thing than someone who is using it because pain is keeping them up at night. That person using it for chronic pain that's hurting them all night, that might help. It also, if you have PTSD and you have nightmares, it might help. I heard a very interesting study about CBD that suggested that some people had benefits for sleep if they took CBD in the morning. And that was for anxiety, though, right? So you're less anxious through the day and over into the night. And then you don't get the fact that some people, and it seems to be like a dose dependent effect, that low dose makes people a little anxious and higher dose makes people maybe a little more sleepy with the CBD. But there there are reasons then that if that might interfere with someone's sleep, that then might mean that it's useful. But primary insomnia continues to strike out in the medical literature. And again, we want to hope that it can help, but when we're looking at it, it seems like people have less REM, less restful sleep, less deep sleep when they use THC at bedtime. CBN, a lot of the people I've talked to who are specialists in this say that CBN doesn't seem to work as great as they'd expected. I've a couple of the studies I've seen suggest that CBN compared to placebo, and then they did one study, it was like CBN, melatonin, and placebo, and it did as well as the melatonin, and both of them did better than the placebo. And if anyone's used melatonin, melatonin, it works for some people and doesn't work for others. And I think CBN is going to be kind of the same idea. So if you fail melatonin, CBN might be a good choice. The yes, the now a lot of people, you know, pardon me, I just got a little hair there. um, a lot of times, cannabis gets a bad name. I'm going to throw this one past y'all here. I was talking to someone and I heard something. It was a punchline. I don't remember the setup for the joke, partially because I was only half listening to it until I heard the punchline. And it went like this. The, the punchline was because, oops, sorry. Oh, great. Nice setup there. Um, the punchline was because cannabis doctors need something to do beside, I'm sorry, I messed that up. The punchline was because disgraced doctors need something to do besides be a cannabis doctor. And I was like, what? Of course, then I paid attention to it and I was like, and I think there's something to be said about the fact that the endocannabinoid system, cannabis, there's so much negative stigma around it still that we, even when we try to be our best and most scientific, sometimes people kind of view it as a little bit fringe. That when in fact what we're trying to do is help people. The simple truth is that, as you probably all know who are watching, the endocannabinoid system is a system that is in our body whether cannabis exists or not. That is a real thing. Cannabis, the endocannabinoid system controls a variety of different systems in our body. And as you mentioned, it's on the heart, it's on the lungs. You know, I mean, heck, there was a study to show that people who use CBD chronically had less severe COVID during the COVID epidemic, and were less likely to die from COVID because the CBD did something on the endocannabinoid system that protected you in the lungs. The immune system is part of it. Fat cells, pancreas cells, liver cells, brain cells, the pain system, which is how I, as a palliative doctor, got into this, was the through learning about the pain. The endocannabinoid system is real. And if the endocannabinoid system is real, then we have to use it. We have to, um, hang on a second. No, okay, never mind. As I was saying, the endocannabinoid system is real. And if it's real, that means we have to pay attention to it. It means it has effects on our body. And if it breaks, we have to treat it. And right now, outside of cannabis, we don't have a lot of good treatment options. Yes, I mean, cannabis, so THC plus all the different things like CBD, CBG, CBA, all that. But we don't have a lot of treatment options for people who have a broken endocannabinoid system. The There's really good data about MS. There's really good data about chronic pain. There's really good data. Well, those are probably the two biggest ones. Migraines. There's some good data about migraines. There is good data about PTSD. There's a lot of people who have broken endocannabinoid systems who can benefit. And as a doctor, I'm here because I personally think that we have to come out and speak about it. And the fact that cannabis is illegal kind of puts this whole air over things. People are still getting arrested for using cannabis, which is crazy that it's still federally illegal, and there are still states where if a person was to use it medically, they could get arrested. I don't understand how. Well, I do. We all know, right? I mean, you've had years and years of negative press, reefer madness, followed then by Nixon vilifying it, followed then by years of just say no, and oh, it's a gateway drug. And yes, I do believe there are people who can be addicted to it. I do believe there are people who, when they use it in the wrong way and in a way that can hurt them. But it's a drug that can help people and fix the endocannabinoid system. I know I'm going on my soapbox here. Um, so that is what the endocannabinoid, that's why I'm here. I'm here because I want you guys to know about it. I want the medical world to know about it. I want people to know that there is legitimate medical reasons. You won't hear me rail about big pharma, except for when they really do something boneheaded, because sometimes they do. But generally speaking, or say, oh, modern medicine is trying to keep. No, I think a lot of people's lives have been saved by modern medicine. This is just a part we're missing. And we're missing because of the stupidest reason, which is because of politics, because of people moralizing, people taught something the wrong way and refusing to change, refusing to see that this can help. And that doesn't make sense to me. Why would you hurt people who need this just because you refuse to change your mind on things? You know, how many people have to suffer with chemotherapy side effects and can't get their nausea treated? How many people with autism spectrum disorder with behaviors who respond? How many young kids with seizures? Yes, we do have the new epidiolecs that can help, but there's still a lot of people who benefit from full spectrum cannabis. How many people with chronic pain, with MS? Do we have to punish because a bunch of politicians think it will get them votes if they keep it illegal? Me, I personally advocate for a group called Americans for Safe Access. They don't pay me or anything. I'm not even like a full fledged member or anything. I just really do believe in what they're saying, which is they want, instead of being Schedule 3, and for those who don't know, the DEA has different schedules for drugs that are restricted. Schedule 1, as everyone knows, is the most restrictive. It's drugs that are illegal across the board. Um, by the way, guess what? Schedule cannabis. We all know cannabis is Schedule 1, but guess what Schedule cocaine is? Cocaine is Schedule 2. Yeah, right. Cocaine is Schedule 2. Why? Because they found there were cases of certain eye surgeries and certain extreme nosebleeds. People with hemophilia who's have nosebleeds that won't stop. Cocaine will stop it because it's a very good at vasoconstricting, and it will stop that. Of course, if you've ever heard about people who use cocaine, some of them have their noses like falling in because they snort it, and then after a while, the blood vessels do constrict, and their nose dies basically, and they start getting a flattened nose. Um, but in someone who has hemophilia, whose very much life depends on stopping that bleeding, and hemophilia is a disease where you can't stop bleeding, or you're missing certain clotting factors, and so as a result, you bleed, and so yeah, cocaine is Schedule 2. I legally could prescribe cocaine to anyone. Now, if I do that, I trust me, the DEA would be coming after me if I did that regularly. The and it might be a little hard to fill. It probably could only fill it in tertiary centers where they treated hemophilia. But cannabis, that's cannabis is still Schedule 1 when it can do all these different things. And, you know, I do think that we give it a lot of credit. Um, you know, the some we especially when we talk about the cannabinoids, there's a lot of things we claim it can do based off of animal studies. And it's like, well, we have the world's healthiest rats. Animal studies don't always translate to human studies. It doesn't always mean it helps us. It means it helps the rat. But there's the medical literature is riddled with things that have animal studies that helped. That said, sometimes it might judge because we're not working in an area where it's pseudoscience, where the data says this is wrong. This is not how it works. And we're like railing against science. No, this is how it goes. No, We work in a world where, because of federal laws, cannabis has not been made legal enough for us to get a lot of good studies. Because it can't be patented for big pharma to come out, we don't have a lot of big $1 million, multi-million dollar studies with, you know, 25,000 people to say, how does it help? How does it affect? We don't see these studies because it doesn't it doesn't work, right? We don't, we don't have big pharma. We don't have, you can't get giant NIH grants on this. I know some people got a few little grants here and there, but generally there's not a ton of things like that. And it's federally illegal, so there's a lot of places they can't even do research on it. And so as a result, it is a little bit harder to do the studies. It is a little, and sometimes when you see a study, it was promoted by someone who had a, vested interest in it. They made their private extract. I remember seeing that. I think it was like an Israeli study where they just basically reconstituted. It was like THC, CBD, CBN, CBG, CB something, CBC, and they made their proprietary blend that they could patent. And then they did studies on it. That's going to be a little biased, maybe, right? Possibly. That's why people have to declare their conflict of interests. And then the other possibility is that these small companies that are just trying to do startups aren't going to have the deep pockets to do big studies to really tell something meaningful. And so we operate within a void of information, not because it's useless, but because the studies haven't been done. And so, because of that, sometimes it is a little bit of a guess. Um, One of the more interesting things I read on an animal study, I would love to see on human studies. Oh, thank you. Is one of the things I'd love to see on human studies is THCV. Um, there has been some studies about the metabolism of THCV, possibly weight loss because it blocks um, CB1. Now, I'm a little bit cautious about that. I don't want to jump out and say, okay, everyone take THCV next to your Ozempic to lose some weight because you block CB1. We already did that. Big Pharma, about 20 years ago, Ramambavent came out and it was a CB1 blocker, and everyone was like, the next big weight loss drug, because if cannabis gives you the munchies, we're blocking that so you don't get the munchies and you don't have an appetite. I remember I had a colleague who took me out to lunch, to a dinner. She was an endocrinologist and said, oh, they're taking us to this fancy restaurant. Come join me. And I was a young enough doctor that I'm like, ooh, free food? Yes. And so we went to this, and they told us all about the endocannabinoid system and how by blocking it, we could decrease the appetite. Now, Rimonabant wasn't approved yet, or never would be, it turns out, approved in the United States. So they couldn't say the name, but they wanted us all to know about the endocannabinoid system because they had the drug coming out. Now, it turned out in Europe that, yes, it blocked the munchies, but guess what? We have a lot of receptors in our amygdala, our emotional part of our brain, and you block that, and people increase the rate of suicide. And so it got pulled from Europe, never got approved. And so now THCV does work a little bit different. The binding's a little different, so it may not have the same effect. But I would be cautious about anyone with depression based off of that, giving that to them. And I would say I wouldn't necessarily tell everyone to use it with their Ozempic. But one thing I would consider is there was an interesting study about Parkinson's, and this was just in mice, unfortunately. I really want to see the human study where they took the mouse, and it was a Parkinson's model of a mouse. So that meant this mouse is what they would use to study Parkinson's disease in. And they gave it L-Dopa, which is the treatment for Parkinson's. It doesn't cure it, but it gives you dopamine. You're missing dopamine in the part of your brain called the striatal negral part of the brain. And that dopamine supplementation helps people move better and helps their symptoms. The disease progresses, but you can be more functional with that. Now, the downside is after years of that, the brain changes a little bit and gets used to it. And you can start getting dystonias, which are uncomfortable movement disorders, whereas the Parkinson's is a tremor. Dystonias can be kind of more of a like a frozen neck or little jerky things or different motions, little stiffness, and that can be limiting. So you can't take the drug anymore. And if you can't take the drug anymore, now your symptoms are a lot worse. But you take it and you get these symptoms. You don't, you get these, and eh. So it's something they very much try to avoid. In the rat model, when they gave THCV along with the um, L-Dopa, the rats developed dystonia much later. And then they did a second study on rats who they let develop dystonia, and they gave THCV, and a lot of them got better, not 100%, but their symptoms got a lot better. I want to see that. And frankly, if someone I knew had Parkinson's and was at the point where their doctor was like, "Oh, you got to stop taking this drug and let's talk hospice and let's talk this and that and because you can't take this anymore because the dystonias are bad." I might tell them to try THCV because at this point, what other options do you have? The risk benefits might favor it, but again, the studies don't, aren't there outside of animals. So, yeah. Thank you, Dr. Matt. Well, I appreciate you coming. Thank you for joining here. Um, yeah. So the again, I hope this is really about sort of interacting, and I hope we get a lot of people showing up as we grow here and get more people commenting. you know, let's see. Does anyone have questions? Again, this is Q&A. This is ask your questions. Hit me up. Uh, the but if if you don't, I'll just keep talking, I guess. the I had mentioned earlier, I think before we went back to talking about the importance of small doses and stuff like that, women, and it is interesting that there's that actually is a growing amount of data even in human studies. I actually recently gave a lecture about pain and cannabis, and I had two doctors who were actually co-lecturers who were watching, and one was giving their lecture about pelvic pain and what they do, and the other one was a physical therapist talking about different types of pain. And both of them chimed in that yes, they use it for their patients too, that it does seem to help a lot of the pelvic pain syndromes. So again, if someone's struggling with endometriosis, obviously talk to your doctor. There's even some people who swear by vaginal suppositories. I do want to say you want to make sure you get one that's very clean and very, make sure you know your source if you're going to do that. But some people will even take it oral. And the other caveat of vaginal suppositories, if you're using it, especially if you're using it for painful sex, you got to let your partner know. You don't want them possibly absorbing it and getting high. Right? Uh, Now, in the hospice world, I do a lot of stuff with hospice, and It's interesting because I even asked the hospice I worked at, I said, "Hmm, we should advertise that we're canna friendly. After all, I know a lot about it." And they said, "We can't because Medicare pays for hospice. And so we can't talk about it." And I'm like, really? And it's true. It's the You know, I think that's why a lot of doctors don't like talking about cannabis and stuff. It's because there is this fear that we can get in trouble, that Medicare, doesn't approve of it. So we can't talk about it. In fact, we got these state things that even say that we're not prescribing cannabis, we're approving it and maybe educating people on it. We're not prescribing it. And, that kind of creates a disconnect. A lot of doctors don't know about cannabis medicine because of that. A lot of doctors purposely kind of keep themselves away. They're like, I'm going to do what I can. I'm going to say yes. But they try not to learn about it because they're scared they might get in trouble. They're scared if they tell their patients what to use, that then it would be considered prescribing it. They're scared if um, they might, yeah, they're scared they might get in trouble. I mean, I'm kind of late to the game, having only joined the cannabis world a year ago. And that's in part because the DEA started talking about rescheduling. And I said, well, if they're rescheduling, then maybe I'm not going to have to worry about them taking away my DEA license. Uh, but that's a real fear a lot of doctors have, is that, am I going to lose my medical license? Am I going to lose my DEA license? This is our bread and butter. This is how we live. And there's a lot of fear in medicine that this will, that doctors who do this are putting themselves at risk. And I'm here to say your patients are using cannabis, whether or not you want to think about it. Your patients are using cannabis, whether or not you want to think about it. And so every doctor needs to know about cannabis medicine, at least some basics, at least a little bit. You need to know drug interactions. You need to at least give your patient a little bit of advice. You need to know what's out there. Otherwise, you're leaving them to the bud tenders to tell them, and that's not good medicine. you know you need to know, is this addiction, or is this someone chronically using because they have a disease that chronically needs it? Is this addiction, or is this someone who is using it every day, right? Like I said, but then there's another group that is using it every day because they're not being treated medically. They could benefit. So, someone with anxiety, someone with PTSD, maybe what they need is cognitive behavioral therapy, and you need to send them over to offer it, right? Maybe what they need is some other treatments. You know, maybe they have an autoimmune disease that you haven't looked into, but they woke up every morning with sore muscles and heard cannabis can help it, and now they're taking it. Meanwhile, they have rheumatoid arthritis or lupus, and you're not doing the workup for it because you're just lecturing them about being a cannabis. Oh my God, you're using cannabis. You know, maybe if you stop the cannabis, you won't feel so bad. Well, maybe they're using the cannabis to treat a symptom that's not being treated right. So there can be a lot of reasons people are using it medically that need to be addressed. So, yes, someone could be abusing it. And yes, there are people who aren't abusing it, who are using it every day, like your MS patients or some of your chronic pain patients. Use it every day, and they use it responsibly, and it helps them get through their day. But then there's people who are using it, maybe not using it the best way, but they're using it because they also need something else. You know, a classic thing. Another classic example is PTSD, I often say. PTSD has really decent evidence that cannabis can help. Among other things, it can help the nightmares. I talked about sleep before. That REM suppression is not great, but PTSD, if you have less REM, you have less nightmares, which means a person with PTSD might actually get a better night's sleep. That's a good thing. And it also helps um, some of the sort of thoughts and stuff, some of the racing thoughts, some of the intrusive thoughts seem to respond well to cannabis in people with PTSD. But the treatment of choice for PTSD is therapy, like cognitive behavior or EMDR therapy. And if you see someone on cannabis and you've never asked them why are they using it, if you're a doctor, why do you use it? What helps you? And you say, well, I had bad PTSD, from combat, and now I use it. That is a thing. You know, if you that's a cue that one, maybe it's okay they use the cannabis. Two, that you need to look at some other therapy. Now, the other end of that, though, is sometimes people with PTSD and other medical conditions, sometimes they're not using the cannabis to get through the day to help them. Sometimes they're using it sort of like you might use alcohol or some other drugs to kind of hide away, right? To say, I'm going to stay in the smoky haze and not worry about anything and stay in my home, and relationships suffer and jobs suffer and their life suffers and they're not living their best life because they're hiding from it. And again, that's where helping someone get the therapy, maybe they don't stop the cannabis, but maybe they use it in a way that's healthy as opposed to a way of where they're hiding from things. So that's kind of where I think as doctors, we need to work on approaching things a little bit. Uh, Recognizing that cannabis is real, that the endocannabinoid system is real. Recognizing that there are cases where we might need to use cannabis to help people. Right? The That is sort of what we do. That's kind of how we think about it. At least that's what I recommend. Uh, I'm trying to think anything else on my soapbox here today. Um, um, Again, anyone's welcome with any questions they might have. I know I can talk nonstop if I need to. I always joke that if a politician ever needed someone to filibuster, I'm your doctor. I'm the person to go to do that. The Yeah. So let's see. 7:54. We got a few more minutes. You know, I would say that if you see this, if you're, you know, talking to people and stuff, one thing you should do is definitely talk to your politicians. Let them know that this isn't a bunch of people who are just about, getting high and gateway drugs and all that stuff. There's real people who are suffering. There are real people who need help. There are real people who need cannabis. And sure, someday in the future, big pharma might come out with a drug that's better than cannabis. You know, there's been a lot of different plant drugs over history. Sometimes things like aspirin, which is a from willow bark, stays the same, and it holds the test of time, and it's been there. Aspirin not only can help with inflammation, it helps with the heart. Right? The Then there's drugs like digoxin from the foxglove plant. Again, an herbal, right? And It is not the best drug out in terms of things, but there are still several people who do better with the Jackson than without it for their heart. There's been a lot more heart drugs that have come out over the years that have helped better, but there are still people who need digoxin. The Pacific Taxol, which is a chemotherapy drug, came from the Pacific yew tree, and they got an extract from that and made a chemo drug. And that's still very much being used for breast cancer. There's a lot of meds that come from plants. Now, being all natural does not make everything healthy. There's a lot of nasty, poisonous stuff in the world that comes from uh, plants. Mm. Atropine is a natural extract. It used to be called belladonna. Women would put it in their eyes to make the eyes look big and pretty. The But it actually can be used for certain medical conditions. So we use it in a CPR and stuff like that. So yeah, like I said, a lot of different drugs act medically, and I don't see why cannabis, a lot of different drugs, obviously, I'm sorry, a lot of different drugs come from plants that then have medical benefits. Um, Here's my chamomile tea, right? Chamomile tea has anti muscle spasm effects. Another woman's secret for years that have been used for for um, for centuries by women for for period pain because it has some smooth muscle relaxing effects. Mm. But this one medicine that can help people in a world where cocaine is Schedule 2, where I could prescribe cocaine if I wanted to. I can't legally prescribe cannabis. So, as I was saying, the Americans for Safe Access, to circle back to what I was saying, they have a program where they want to make it Schedule 6. So, Schedule 1 is fully illegal. Schedule 2 is I can prescribe it, but it's highly regulated opioids, cocaine. Schedule 3 is like your Tylenol, um, Tylenol 3. Schedule 4 is a little bit lighter, Schedule 5. And Schedule 6 doesn't exist. They actually want to create a Schedule 6 to say this is cannabis and it should be regulated in a way that makes sense. So, we got a thought here. Let's see what we got. My friend has a Parkinson's for several years. She's on a traditional pharmaceutical to slow the progression of the symptoms. She's not tried comfort for fear of mixing with the pharmaceuticals. You know what? I'm okay with that. There is some data that there is some data that it can help with Parkinson's, and it's because the CB1 receptor downstream does activate the dopamine at the striatonigral part of the brain. But frankly, if her Parkinson's is well controlled, I would say, nah, it's okay. You know, I would right now at this point, if someone had something that wasn't controlled and they were trying to tweak it a little bit better, you might try it. Um, and like the THCV, if you were really at the end of things and you wanted to see if you can't get a little bit extra out of that, I might try it. There is data about Parkinson's, but I wouldn't necessarily, you know, I, if it's working for you, I wouldn't mess with it at this point. Not yet with the data. I think in a few years we might have some lot better data about Parkinson's and it. And the other possibility is, remember I was saying that L-DOPA kind of wears off. If it is activating on the striatonegral through the and you're actually getting dopamine, we don't know long term over the course of many years how that's going to act. All these studies that we've done so far with cannabis and Parkinson's have been fairly short. I would think of it as a palliative possibility, or someone, again, maybe THCV as a palliative possibility, but I wouldn't yet recommend it because we don't know if that endpoint where the meds work or don't work is going to be hastened by especially THC. I don't know. And so I'm okay with her not being comfortable with it, especially if it's working for her. So, but yeah, that is, yeah, that's where we're at for today. It's 8 o'clock. I'm going to call it a night. Um, Thank you guys for joining. Appreciate your insights and your questions. We'll be doing this every Thursday at 7 o'clock from now on. I still will for now have the 3 o'clock on Wednesday. And then if there's any physicians, I do on Tuesday at 7 o'clock have a special thing, a webinar where it's less Q&A and more me going to be presenting for about 20 minutes on 3 things that every physician should know about treating their patients who use cannabis. Okay. I hope you guys all have a great day. Take care and enjoy your night.